Are we here?
Hi!
Hi. How are you?
I'm good. I'm so sorry. It took me a minute to get situated here.
No, it's taken Instagram a minute to get situated. We've been trying to connect for 20 minutes.
No worries.
What's that?
I said I'm here now. So nice.
I know. So good to see you. Thanks for coming and joining us today.
Sure. My pleasure.
Yeah. Well, hello, everyone. Welcome to the Cervical Chat, Sex and Intimacy. I'm Aisha McClellan. I'm the Cervical Cancer Program Coordinator at SHARE. Please share in the comments where you're joining us from today. Before we begin, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who's been diagnosed with breast and gynecologic cancers, and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars and support groups and our helplines, please visit sharecancersupport.org. Feel free to submit any questions in the comments. Remember that we are unable to give specific medical advice, so please keep your questions general in nature. Now, I would like to hand it over to Dr. Rojas, who will introduce herself.
Hi. First of all, can you hear me okay?
Yeah.
Okay, perfect. My name's Dr. Kristen Rojas. I'm a breast cancer surgeon at University of Miami, Sylvester Comprehensive Cancer Center in Miami, Florida. I'm also a board certified gynecologist. The majority of I wear hats. Usually for most days of the week, I'm a breast cancer surgeon, but I also run the sexual health after cancer program called MUSIC. It stands for Menopause, Urogenital, Sexual Health, and Intimacy Clinic. And it also has its own Instagram, which is music_sex after cancer. And I treat women with a history of any type of cancer, or women at increased risk of developing cancer who are experiencing sexual side effects from treatment, such as vaginal dryness, painful sex, low desire, menopausal symptoms like hot flashes. And so that is, so I'm here to answer any of your questions and talk more about that. Thank you so much for having me.
Yeah, awesome. Thank you. So we have a few questions to get started. Can you tell us more about your work on sexual health and cancer, and specifically the MUSIC program?
Sure. So when I first started my career, I realized I'm not sure if patients were telling everyone these symptoms, or if for some reason people had looked me up ahead of time and knew I was also a gynecologist. But I felt like almost everyone I was speaking to had some concerns about either the side effects of the medication they were getting that we were recommending for them, or had already experienced side effects, and side effects maybe that they don't feel comfortable talking about in front of other people. And they all asked me about them, and I was really struck by how common these concerns were. And when looking more into it, I realized that over 80% of female cancer patients experience sexual side effects. And it's like historically a very under-addressed and under-recognized issue. Mm-hmm. We are essentially putting women into menopause, young women into menopause, and women who've already experienced menopause, worsening their menopausal symptoms. We're changing their fertility options. We're changing their sex lives and their support system, and we're not talking about it at all. And so I think this is indicative of a bigger issue culturally, how we just don't talk about menopause at all, but also a very under-recognized problem for women diagnosed with cancer, especially young women, but older patients as well. So in the MUSIC program, we really focus on addressing just these symptoms. So a lot is going on when patients are newly diagnosed. They're trying to explain what the diagnosis means, what the treatment is going to be. So the program really sets aside another time where we can talk one-on-one, and there is an exam involved, because oftentimes patients are experiencing dryness and painful sex. And so we do an exam, we check all the pelvic floor muscles and specific areas where patients are having pain, and then we treat those issues. And then first visits are usually an hour because we have a lot to chat about, and then we see patients in follow-up, and then most patients can be discharged from the MUSIC program and go back to their lives after we've given them all the tools to tackle some of these issues.
That's awesome. So does it work kind of like a clinical trial? Is this something like an added service, or how does that work?
Yeah, I tell patients to think of it like a super subspecialized GYN visit. So like your primary doctor, your gynecologist might refer you to like a super specialized gynecologist who focuses on one thing. And to think about it kind of like that. It's a one-on-one doctor's visit, and we usually have some follow-up visits. People sometimes ask me if it's like a group setting, like support groups, and it's not that, but we have resources for those for patients that want them.
Okay, awesome. And how many hospitals is it located in?
It's actually right now just the Sylvester Comprehensive Cancer Center,
Okay.
University. But a lot of what I do is educating other providers across the country on how to start similar programs so that it doesn't matter where patients are, that they can have access to these. I also created the Instagram so that patients outside of the United States can have access to these options, this information. And it's like I have patients that write me from the Philippines, from LA, like it's really wild being able to reach that many people, but it also speaks to how common these issues are.
Absolutely. That's fantastic. Wow. I just that's wonderful. So do you see patients remote? I mean, do you see patients like on Zoom in different locations?
Yeah, I see patients, but it's better to be able to examine patients because often one situation is a little bit unique. If you want, I can talk about, I'm sure some people are tuning in because they have some of these issues and they might want to.
Absolutely, yeah.
I'm happy to, I'm seeing comments from Stephanie Sabon. This is so cute. Hi, Steph. So I can talk about that if you like. Yeah.
Yeah, that'd be great. That'd be great. Yeah, we have some other questions that were sent in, and so we can start
with that. Whatever you want to do.
Okay. So, in your experience, are the issues between breast cancer patients and gynecologic patients similar?
Oh, that's a great question. People, even if they do recognize that there are sexual side effects with treatment, oftentimes people will only think of GYN cancer patients for that, or they'll only think of breast cancer patients. Honestly, breast cancer seems to be the most visible women's cancer because there's so much fundraising and stuff and all these like advocacy groups behind it. There's starting to be that more for GYN cancers as well, but I think for like the general population is still kind of unbalanced in that sense. So I think people have a lot of misconceptions about who these issues affect. And honestly, breast cancer patients who've gotten chemotherapy, breast cancer patients who are on endocrine therapy or estrogen suppressing medications can have similar side effects and similar symptoms to GYN cancer patients who've had pelvic radiation. Like sometimes I really can't tell whether a patient been on a aromatase inhibitor like letrozole, anastrozole, or exemestane for 10 years, or a patient had pelvic radiation, because every woman's body responds differently to these changes in hormones. Right. And what I learned is we can't make any assumptions. A lot of these symptoms overlap, and some women may have no symptoms and some women are extremely symptomatic. It's really hard to predict who's going to be the most. It's not just the young patients. It's not just the old patients. It's not, older patients. It's not just patients who get pelvic radiation. And so in the music program, I also treat patients with other types of cancer who, believe it or not, experience the same symptoms. Colon cancer patients, lung cancer patients, brain cancer patients, leukemia, women who experience cancer treatment or get chemotherapy, radiation. Even the psychological impact from a diagnosis can cause sexual dysfunction. So it's, no one's safe to say this.
Yeah. Wow.
The other thing, they've done studies for prostate cancer patients, and they're informed of sexual side effects from treatment like at the first visit. Most of those patients get information that prostate cancer treatment can cause erectile dysfunction, and women obviously are not getting that same kind of information.
Right, exactly. I had no idea when I was diagnosed. I had no idea. I mean, even at the end of treatment, they're like, you're gonna be put in early menopause, and they told, but they didn't really I didn't know what that meant, or is his menopause something that you know, it's like, does it just happen like one time? Like, I mean, I didn't know. Like, is it a journey or is it a destination? Like, I didn't know, you know? I had no clue. So, I mean, it's fascinating that they tell prostate patients that initially.
Yeah, we're essentially chemically castrating women to decrease the risk of recurrence. We're not calling it that, but like it's what we're doing. I mean, yes, of decreasing cancer recurrence, improving survival. So we want patients to be able to think of cancer as a chronic disease and not a death sentence. You know what I mean?
Yeah,
And it's
absolutely.
all in the name of that, which is good. So like, I don't want to inhibit that progress,
For sure.
but we have to call it what it is, and we have to address those side effects so that patients can tolerate the treatments that we're giving them.
Exactly. One of our questions, well, somebody left a question in the comments. Would you suggest vibrators or dilators for vaginal patency?
That's a great question. So a lot of what I do is treating dryness and painful sex. So when we're talking about vaginal dryness, the tissues of the vulva and the vagina, so the vulva is the outside and the vagina is internal, are very sensitive to drops in estrogen. So while we used to say vaginal atrophy, which basically means like thinning of the vulva and like less stretchiness and dryness, what we say now is genitourinary syndrome of menopause, or GSM. So this includes symptoms not only of dryness and painful sex, but it also can change the shape and the size and the length of the vagina. So even though we've called it, oh, you're going to have some vaginal dryness, it's not just vaginal dryness. And that's what we're trying to inform other providers as well, that when we don't treat these issues, the shape of the vagina changes. And for patients who are engaging in penetrative forms of intercourse or sexual activity, there's a lot of different kinds of sexual activity. Yeah. But for those patients, it can be almost impossible to continue to engage in that form of sexual activity when the vagina narrows and shortens. Right. So I think what the person is referring to with patency is the like shape and size of shape and length of the vagina. Okay. So to treat the dryness, the pain, the stretchiness, but we also talk to patients about dilators. So for patients who are not currently sexually active or like having penetrative intercourse during treatment, we often recommend a dilator, which is like a rigid plastic tube, place silicone-based lubricant and place it in the vagina 3 times a week for about 10 minutes. I tell patients to try that. This does 2 things. Number 1, it helps to stretch out the tissues and kind of remodel the vagina back to its original state. But number 2, it also helps with relaxing the pelvic floor. So the pelvic floor is like a basket of muscles like this. And so when patients start having painful sexual activity, one of those muscles can spasm and create this like cycle of, oh my gosh, pain, more spasming. And so a lot of what we try to do in music is train patients or teach patients how to relax those muscles. So if you say like, it's the opposite of Kegels. Like people are always talking about Kegels and ask me if they should do Kegels. The answer is no. Most people should not be doing Kegels. Yeah.
Really?
Yeah, because for this population, because a lot of what we're trying to do is the opposite, relax those muscles, right? So you can't like just snap your fingers and relax your pelvis. Like it's not like that easy or even possible to do that. But what I do tell patients to do is when they place the dilator, to take their hand and place it like halfway between their hip and their knee, like on their inner thigh muscle, like that little skinny muscle kind of halfway between their leg. And if they can concentrate on relaxing that inner thigh muscle, like halfway to their knee, then the rest of their pelvis is relaxed. And so dilators do 2 things. They stretch the tissues of the vagina, help with the stretchiness, but they also can help you kind of retrain the brain and how to relax those muscles. So during sexual activity, you don't have that anticipatory spasm from all these episodes of pain that you've experienced. So to answer that question, a dilator, we think of this as like a medical grade device in different sizes, but really like an internal vibrator does the same thing. It can You can place the vibrator. It doesn't necessarily have to be turned on, but it still is kind of like helping to stretch out the tissues. You can do the same thing where you're trying to relax those muscles. If you want to use the vibration portion of it, like go for it. Obviously, and then for who also have a lot of spasm, a lot of times, but so there's kind of like different issues that come up. So some patients have this pain, but they're still able to have an orgasm, no problem. Whereas other patients have a lot more challenges with orgasm after treatment. So for the patients who still have their orgasm intact, like where they can still reach that level through whatever format or method, we oftentimes, but they're having pain with sex, but like penetrative sexual activity, I'll often tell them to try to have an orgasm before starting penetration, because that can help also relax all those muscles. And so for those patients who are still able to do that, it can be really helpful for them. Yeah. It's more complicated for patients who have more challenges with orgasm, and we talk about that. But so to answer the question, vibrator, dilator, anything that's a space occupying firm, even if you like. So what I tell patients is we're going to use this dilator for a while until you have sexual activity like once a week, because then if you're doing penetrative sexual activity, it's like you're using a dilator. Okay. Yeah, like a bridge.
Gotcha.
To get.
Okay. Speaking of, is it okay to have sex during treatment?
Well, it depends what kind of treatment. So most of the time, yes, especially if it's like endocrine therapy, like estrogen blocking medication. You know, once you get the clearance for like going back to the gym and doing like aggressive physical activity, usually that also includes sexual activity. But for patients who've had GYN surgery, you do want to make sure you get specific clearance for that from your gynecologist, because there's like nuances to how your surgery was done, and they may give you like a certain number of weeks. Sure. With regards to pelvic radiation, we typically don't have patients continue to like be like penetrative sexual activity during that time for obvious reasons. You know, there's a lot of different ways to be intimate that's not just penetration. And so we do try to encourage patients to continue to be intimate, and if they're partnered during treatment. But for like the details of like what that looks like, sometimes it's good to get clarification from your doctor. Yeah. For patients who are getting chemotherapy, who have really low white blood cell counts, so the patients who have like leukemia, lymphoma, who get really aggressive chemo, they really need to just touch base with their oncologist on when it's safe to have sex again. And usually what they say is like to use condoms for a while, if you're relying on them for STD or pregnancy protection. You know, and the other thing you have to think about is if we're able to get pregnant, like you don't want to have an unplanned pregnancy during treatment. Right. So yeah, it's not just because it introduces like, you know, a lot of issues like, do we stop treatment? You know, and obviously there's a lot of political issues surrounding early pregnancies. And so it's not just about sexual activity. If you can get pregnant, you also want to think about reliable contraception, which those, depending on your treatment, can be different. So good to talk to your doctor about what they recommend. Gotcha.
If you are able to have sex during treatment, would chemo or radiation harm my partner during sex?
Oh man, they're really good questions. So chemo, sorry, things coming through. Chemotherapy is tricky. And that's something that they should discuss with their medical oncologist, because it's chemotherapy. A concern, if there's a concern,
of all the toys in the world.
If there's a concern, the partner coming in contact with that, you can always use barrier protection if it's penetrative sexual activity. With regards to radiation, it depends on the type of radiation. We usually breast radiation, like we don't tell those patients to like avoid, you know, it's not like when you get your thyroid radiated and you have to take that medicine, like have to use your own toilet and can't be too close to anyone. Like it's not like that. So it's on the type of radiation, but usually if it's breast patient, it doesn't matter. But if you're getting like different immunotherapy agents or chemotherapy, probably good to have barrier protection while you're receiving those agents. But talk to your oncologist to confirm. And you know what? Like, speaking of talking to your oncologist, a lot of people are embarrassed to ask their oncologist these questions. But honestly, like, you may ask them this question and they have like a crazy look on their face because no one's ever asked them this question before. But we all want to help our patients. And if 5 patients ask me a question about whether they can have sex on this certain immunotherapy at that time, that day, even if catches me off guard and I don't know the answer, like, I'm going to go home and figure it out and find the resources for those patients. So you have nothing to lose. Like, you've already you're being subjected to all these treatments that we're doing. It is a team effort. Like, we need your buy-in on your treatment plan. 100%. So like, even if you're uncomfortable, like, don't be, even if they have a crazy look on their face and they don't have the answer, ask them again next time, because they might have looked it up for you or asked some of their colleagues.
Exactly. That's great advice. Great advice. What can women do when they're struggling with low libido?
Yes. Low libido is like the hardest hardest symptom to treat because it's complicated. So, you know, in music, what we do is start with treating the pain and dryness, if that's an element. Because if you're experiencing a lot of pain with sexual activity, your brain is not going to be like, let's go do that again. Like, for most of the time, there's like special, I guess.
Yeah.
But so we want to focus on treating the pain, the dryness, and then I have patients like really assess, is this a relationship issue? Like, do I need to kind of sort some stuff out with my partner? Would it be helpful for me to talk to someone? Do we need to work on communication? I tell patients, like, anytime you're going to talk about sexual activity with your partner, it should not be in the bedroom. Like, it should be at another time. Like, set aside time, not when it's game time, to have these discussions with your partner.
Yeah.
I've seen, like, my own anecdotal experience in the music program, is that most partners, like, actually do want to be involved and want to kind of get this information so that they can be the most helpful. They just don't know how. And so I think it's a good idea to kind of try to have those conversations with your partner. Let them know, you know, these are what you're experiencing and these are the resources you're looking into, and whether they'd be open to like having more communication about that if that's not already a thing. Now, so those are the like partner aspect and the physical pain aspect. But desire is like a brain thing. It's a central mechanism, meaning it happens in your brain. So it's either that the brain is making the signal and the vagina isn't hearing it, which might happen with like radiation when some of the nerves, or you know, when we drop the estrogen really low, or it's that the vagina can hear the signal but the brain's not making it. You know what I mean? Okay. So if patients are saying that like they really want more spontaneous desire, you know, I talk to them about like, well, first of all, you've been through this huge trauma of a diagnosis and are probably like managing all the other things in your life. Exactly. So really have to, it sounds lame, but schedule sexual activity or schedule like encounters. So like if you have something marked on your calendar, like, okay, Thursdays or Saturday morning is the time, then not only can you prepare, think about it every day. So like every time you use that part of your brain, it's like lighting up that pleasure center, which you think part of your brain as like a highway where all the lights have gone off, like no cars are going to go down that highway, right? So you have to like you work your muscles in the gym, you have to try to think about like some sort of sexual activity or something pleasurable, like even if it's not sex related, every day. And that's like patient's homework, whether it's like watching a TV show that has that, or a movie, or listening to a podcast, or like whatever, reading a book. So you have to work on turning that area on. But also if you've scheduled a time, it takes the pressure off for others, because often patients on me, oh, I like never know, like I want to be a good partner, but I've got like all these things going on. Like every day I'm like, is he gonna ask, or are they, or she or he or are they not gonna ask? Or so like if you put on the calendar, then you're good. So resources that have more information like this. So the Rosie app is a great resource that is an app created by a gynecologist, has a lot of information for patients with low desire, with or without a history of desire. 2 things to prepare for that time when you schedule it are 2 podcasts. One is Dipsea, Dipsea. The other one is Quinn, Quinn. Tryquinn.com, I think is the website. So these are essentially like sexy stories you like to get in the mood. So if you've got it figured out, you're like doing all the things you need to do to get ready for that time. And then you can just plug your little AirPods in and listen to the story. And there's literally something for everyone on these.
Interesting.
And they're actually created by women and directed for women. And so I heard a podcast from one of the founders of Dipsea and was just really impressed with them. So that is a resource to get in the mood. Let's see. Oh, exercise also improves body image, increases natural testosterone. I talked about waking up the brain. And the last thing, 2 FDA-approved medications to increase desire. Once we've tackled everything that we can, like without medications, because most of my patients aren't that enthusiastic about taking another medication. Yeah. If there's still some residual low desire, we can talk about 2 things. Number 1 is called flibanserin. It's the pink pill. You can look it up online. It's a once-a-day pill. I have patients take it at night, and it actually works in the brain, not hormonally, to stimulate that desire part of the brain.
Oh, interesting.
Yeah, it's a serotonin modulator. So for patients who are like on large doses of antidepressants, you just want to talk to your doctor and make sure there's not an interaction. The website for the company, though, has a lot of good information on interactions, a phone call with questions. When this drug first came out, it was like had a lot of regulations on it because there was somebody I don't know exactly the number, but there was an issue with combining this drug with alcohol. And the question was, does this cause like really low blood pressure if someone's drinking and they take this pill? But I'm sure y'all have all seen the warnings for Viagra in drinking or Viagra in heart. Like people can die from taking Viagra and being on certain heart medications, and it is widely available to everyone who wants to, and so once again, in my opinion, this is like my personal opinion, it's like us taking away the like ability for women to kind of like make these decisions on their own.
Right.
So what I tell patients is if you're going to have more than 2 drinks that day, just skip your pill.
Okay.
That's the first option. Second option is called bremelanotide. I don't really want to say the brand names on here, but
okay.
I mean, I guess if I say both of them and they're the only 2 FDA-approved medications, it's okay. So flibanserin, the pink pill, is Addy, Addyi, and bremelanotide is Vyleesi, Vyleesi. Okay. Vyleesi is an injection you give yourself before sexual activity.
Oh.
Yeah. Also works in the brain, increases, you want to do it at least around an hour before sexual activity, and only 1 injection for 24 hours. There's a maximum number of injections you can give yourself per month. I have less experience prescribing that, although the feedback I've gotten is pretty positive. Most patients aren't super excited about another injection.
Yeah.
Yeah.
Imagine.
So those are the 2 pharmaceutical options, FDA approved for low desire, not explicitly tested in cancer patients, but not hormonal. So if you're on like a newer drug for your cancer, I oftentimes recommend we talk to the pharmacist for the companies to make sure there's not interactions, that's not making one medication less or more effective. There are some studies looking at Addy in breast cancer patients on tamoxifen because there is an interaction between tamoxifen and Addy. Okay. So that doesn't mean it's impossible to take. You just have to change the way you dose it.
Okay.
So more information is coming out on that, and we'll post some more information on the music Instagram, but that's the one on that. There's a lot of like supplements that claim to increase desire, and like patients often ask me about that. I really try to stay away from supplements because we don't know all of the ingredients in supplements. They're not, even if they say they have a lot of something with like a interesting sounding name like horny goatweed or like whatever.
Right.
Like, you don't even know that that's like what's in there because no one's checking. And they've done studies looking at kind of scary stuff, looking at those non-regulated supplements. So I try to kind of stick with the things we know are going to work. And then, and other times there's supplements that might have different hormone-like chemicals in there. Like there might be some estrogen-like substances in some supplements. And so we try to stay away from those in music, although sometimes we end up using them, but that's kind of our philosophy. That was like the longest answer to your question.
No, but it was, I mean, there was so much information though. I love it.
So complicated. The end.
It is. And there's so many caveats. You think you're adjusting like one thing and then so many other things come up. So yeah. I love that. Do you have any tips for vaginal dryness?
Yes, this is like a number one thing we treat in music. So the first thing with dryness is understanding like why it's happening. So number one, it's from the estrogen in your body dropping, which causes the tissues of the vulva and the vagina to become very sensitive, thin, and less dry. But the other, sometimes patients, when they start to experience these symptoms, they may use some over-the-counter products. Like there's an entire aisle in the supermarket dedicated to like feminine products, like feminine washes, like, and they have, sorry, it's just timed out there for a second. They have tons of artificial fragrances that women can actually be allergic to and not even realize it. So if you're someone who's experiencing dryness with like itching and stinging, that might be related to an allergic reaction to some of those products. So the first thing we do is have patients stop taking any of those products. So anything with artificial fragrance, the detergent you wash your underwear with, soaps, bubble bath, bath bombs, things like that. And for patients with really mild symptoms, single ingredient organic coconut oil to the external vulva and the vagina is a really good starting point because it can protect the delicate skin of the vulva and the vagina, especially if it's really irritated. It's a natural antimicrobial and antifungal, meaning that it decreases infections. And so that's a good starting point. We oftentimes start there before bumping up to another product. Another option for patients with dryness who can't use hormones is a hyaluronic acid vaginal suppositories. So hyaluronic acid, just like the stuff in your eye cream, they can also put it in vaginal suppositories. There's a brand name called Bonafide that has them, but there's also a cheaper CVS version of hyaluronic acid suppositories. So look for it. Yeah. And so you place these in the vagina 2 to 3 times a week on days you're not planning sexual activity. So we want to focus on moisturizers, which are different from lubricants, which are like in the moment for that. And then for patients who can get vaginal hormones, so actually most GYN cancer patients can get vaginal estrogen without a question. Ovarian cancer, cervical cancer, vulvar cancer, no problem at all. You're having dryness, my first go-to is like coconut oil and vaginal estrogen, okay? And the only thing is that uterine cancer patients, we usually don't start with vaginal estrogen. We might do it later, but we try not to. Breast cancer patients, it's more complicated. There's a lot of controversy surrounding this. So I try to treat patients with non-hormonal options first, but sometimes we end up using vaginal estrogen. There's also another vaginal hormone called vaginal DHEA or vaginal progesterone. It helps decrease pain with sexual activity without increasing estrogen in your body. So it works a little bit better than those hyaluronic acid suppositories for patients who are still having pain without causing all the drama of estrogen in a breast cancer patient. Lastly is lubricants. So I have patients do that for a few weeks, like do something with that's moisturizing 2 to 3 times per week, plus or minus a dilator. And then lubricants, everyone is like really into water. Like everyone always says, oh, I use a water-based lubricant. But if you're not using condoms for STD or pregnancy protection, you should be using a silicone-based lubricant. They last longer. Water-based lubricants tend to dry patients out more. You have to reapply them, sticky. So there's a really great silicone lubricant called Uberlube that doesn't have all of those gimmicks, parabens, fragrances, things like that. So you really want to just, again, read ingredient lists, make sure you're staying away from anything with artificial fragrance. So Uberlube is great and it's compatible with some condoms, but you just have to check. It's compatible with latex condoms, but I think not polyurethane condoms. Okay. So you just got to check if you're using condoms. But I always tell patients silicone-based lubricant.
Okay. Yeah. I love your answers. They're just, this is so in depth. I love it. It's great. We're learning so much today. And so you answered the second question. question. Yeah, are there specific products you would suggest?
Yeah.
So
yeah, let me think if there's any other ones. So those
okay.
hyaluronic acid suppositories are like a go-to. We strongly endorse Uberlube for most of our patients. Oh, I know. This is great for GYN cancer patients too. Is
Okay.
the So actually, I might have one in my office. Hold on.
All right. Awesome.
Oh my gosh, we're in luck. I didn't even plan this. So this
I love it.
these are like essentially stretchy silicone rings, okay?
Okay.
They come in a 4 and they're stackable like this.
Mm-hmm.
See? And what you do is you place these stackable, I don't have any lube on here, silicone rings on this dilator. We're just gonna pretend. And it basically, it's not very scary. Hold on. People were walking by my office being like, what?
What is she doing?
Okay, so you have these are 2, right? So these are like a bumper. So you can place these on the penis or whatever device, and it functions like a bumper, like, and so it actually limits the depth of penetration. So for patients with pain with deep penetration, especially like after hysterectomy, after pelvic, the O nut is awesome. It was actually, I believe, I may be lying, but I think it was created by a woman with really bad endometriosis and those patients often also have painful sex. So this is good for patients who have pain with deep penetration, like in their pelvis. Sometimes it's a combination, so we can use both. And actually, my feedback I've been getting from patients is that partners actually like these and don't mind them.
Oh, really?
Yeah.
Awesome.
Yeah. That
makes sense. Yeah. That makes sense. Wow. That is awesome. And thank you so much for the demonstration.
You're welcome.
Are there other things we can do to address pain during sex?
Sometimes I have patients who are using dilators to, once they're like they start using the dilator without issues, I'll have them talk to their to their partners, about the dilator and actually start sexual activity with using a dilator with their partner. That can be like really educational for the partner, but it helps the patient become more relaxed. That's a really helpful tip for patients who, yeah, those are all the things I can think of right now. Mm-hmm. Oh, one important thing. Patients are often asking me, or not, every once in a while I get asked if they should have a surgery to change the shape of the vagina. Oh. These are very common. In like the celebrity world, they're called labiaplasties. And there are surgeries that are being performed by people that are not always experts in the vulva and the vagina, like plastic surgeons, even hair doctors, dermatologists. And the thing to keep in mind is that women who've been treated for cancer often have very different anatomy than someone who's premenopausal who hasn't been treated for cancer. Right. So me doing something to the vulva and the vagina, like a medical procedure, needs to have a lot of expertise in these differences in anatomy that happen with cancer treatment. So I'm not a huge proponent of surgical treatment for some of these issues because a lot of the issues we can manage without surgery. Surgery can also cause more scar tissue, damage to the infection, more pain. And so along the same line, I actually just did a podcast with breastcancer.org about this, where we talk about some of these like fringe treatments. Mm-hmm. I strongly do not recommend vaginal lasers for patients who've had cancer. Okay. These have, I'm probably getting for this, but it's Mona Lisa, other like gentle sounding names. Breast cancer patients are often referred for these treatments. These devices work by creating tiny microscopic burns in the vagina. They're essentially like a device placed in the vagina, creates these burns. They claim to increase stretchiness and to like rejuvenate the vagina and like increase pleasure. They claim almost like everything. And they were never FDA approved to be used in the vagina. I take care of women who've been chronically maimed because of these burns, scars, people using them, the anatomy, and people having adverse reactions to these devices. Every once in a while, I'll come across someone who swears it really helped them, and that's fine, but they're not safe to be on the market because they're hurting women. And so I've been like very vocal about this, and I'm just waiting to get my cease and desist letter. But I also wrote an op-ed about it. Yeah. any moment. The op-ed is on, it's like Stat Health News is the blog. And if you just Google Kristen Rojas and lasers and vagina, the op-ed will come up. And you should all, it's got a lot of links and helpful information. So if anyone recommends that for you, say no thanks.
Okay. Good advice.
And treat you.
Yeah.
Yeah.
Yeah. Thank you. Thank you. That was actually one of the questions on my list here. So,
someone asked about lasers or Mona Lisa.
Yeah. What are your thoughts on Mona Lisa Touch or laser vaginal rejuvenation in general?
Yeah.
Yeah.
I recommend.
Gotcha.
And
What
procedures. So these problems that patients experience are underreported because they pay like thousands of dollars for these treatments, more pain, their symptoms are not better, and they're embarrassed. You know what I mean? So someone who knows someone or they themselves, they have been affected by treatment with these lasers. MAUD website. Oh, sorry. Should go to the FDA MAUD website, MAUDE. This is the website that the FDA uses to keep track of all these like reports of injury. And if you look on that, you see that there are breast cancer patients reporting chronic pain, scarring, and that.
Oh, okay. Thank you. Thank you. What is pelvic floor therapy? Do you recommend it? And if so, how can it help?
Pelvic floor physical therapy is a special kind of physical therapy where they help usually relax some of those muscles that are spasming like we talked about before. So I will recommend dilators for patients and show them how to use them, but sometimes they have some trouble or have really different anatomy, like they've had pelvic radiation. So I think it's good to try to look for a pelvic floor physical therapist in your area if you're having painful sex, issues with urination, like leaking urine with coughing and sneezing, or issues with having bowel movements, because all of those muscles are connected, and pelvic floor physical therapists are wonderful at helping either relax or retrain the back, etc. They oftentimes are really in demand and are under have a wait list, so you have to get on the wait.
Okay.
Bonus time. So go ahead.
Is it? So with pelvic floor therapy, does it, in addition to helping with like pain, would it also have too much scar tissue that's causing bleeding during sex or something along those lines?
Can it help with scar tissue?
Yeah.
Yeah, they can definitely have scar tissue and help with issues like that as well. But anyone who's having bleeding after sex should also make sure they're getting checked out by a regular gynecologist.
Okay.
Yeah.
Okay.
I'm really worried my phone is going to die. I can't find my charger. I'm so sorry.
Oh, no.
Hold on.
Okay.
I have like a stand-up charger. Oh my God, it's so embarrassing. I'm sorry.
It's okay.
I can get it to charge while it's sitting up there. Okay. It's charging, but I'm on 6%. So if I lose it then.
Okay. We're almost done anyway, but hopefully it'll hang in there for a few more minutes. So got it. So that can are there other things that can be done for like just an excess of scar tissue?
A lot of the things we talked about, like dilators, are really good for scar tissue.
Okay.
Pressure.
Often losing you, like in and out. Can't hear you. I wonder if your charger is blocking the.
That's okay. I'm back at 9% now. Okay.
Okay.
Can you hear better now?
Yeah.
Okay. So vaginal hormones with dilators can be really helpful for patients with scar tissue, but even if they can't use vaginal hormones, dilators, moisturizers can slowly start to stretch out that scar tissue and help. You don't necessarily need surgery to release scar tissue. Oftentimes we can fix it using other methods.
Gotcha. Okay. Okay. What happens if you don't use your dilator over time?
I've had patients like tell me that some people tell them, oh, if you don't use it, you lose it. And I like hate hearing that. It's like not
Yeah.
a true thing. But think of it as like going to the gym, you know, like if you aren't engaging in penetrative sexual activity or using the dilator and then you want to get back into that and your estrogen is really low, so you're losing the strength of the vagina, sometimes that can reverse some of the work that you do with dilator. So I tell patients once you've been using it for like 3 times a week and you get back to sexual activity, you know, if you go through a period where you may not have sex for a while, you can go ahead and just use your dilator once or twice a week. So it's always a good tool to have on hand.
Okay. Okay. Does sex get easier over time?
So just like think of it, it depends on what kind of sex we're talking about. Everyone's different, so that's like a really broad statement. But if we're talking about pain with sexual activity, oftentimes when we treat the pain and get patients back to sexual activity, oftentimes the pain does get better over time.
Okay.
But if sex gets easier in other ways, like that's a little bit more complicated. Depends on the situation.
I see. Okay. What are some ways to discuss issues related to sex with a new partner?
Oh my gosh, I don't know. You know what I think is a great talking to other breast cancer patients or cancer patients who have started dating and have that conversation. I tell patients, like, you know, whenever you feel like the time is right, but don't be afraid to share this information with your partner about your diagnosis or things that you're working on. You know, oftentimes people will have their own experience or know someone close to them that had this experience and already have some background knowledge. So you may not always be the one explaining everything to them because they might already know a little bit. You can also direct them to some of the resources that we've talked about, so that if they want to know more information. And then groups that focus on young patients, like your group, Rethink Breast Cancer is another one that focuses on young patients. They have a lot of resources for patients who are maybe who have questions like that about getting back into things and talking to patients about it. But like I said before, best place to talk about sex is not in the bedroom.
Got it. And how are we doing on your phone?
It's at 5%.
Uh-oh. Do we need to wrap up?
Yeah, let's go ahead and wrap up just in case.
Okay. Well, thank you so much, Dr. Rojas, and thank you all for participating today. This was a really rich conversation. I appreciate your answers. It's been fantastic. Make sure you all check out our upcoming webinars, programs, and support groups. They are pinned in the chat, and also follow us on social media. This concludes our cervical chat. Again, thank you so much, Dr. Rojas.
Thank you, and I'm happy to come back for part 2 time, and you can follow me at Rojas MD for my breast cancer related Instagram, and at music_sex after cancer for the sexual health after cancer Instagram. And I'm also at University of Miami Sylvester Comprehensive Cancer Center. Look me up if you're in the South Florida area, and we'd love to see you.
Thank you. And special shout out to Stephanie for introducing me to Dr. Rojas. And thank you so much.
Bye. Thank you so much.
Bye.